So today we're going to start with concepts of perfusion. So in this class, because you've done this already, I'm not teaching you much that is new. It's a lot of recollection, right? A lot of trying to bring it back to the forefront of your mind so that you can share it and see how much you remember. So I'm going to do a lot of asking questions, and I want you to talk back to me, right? All the questions are in the slide, and all of the answers are in my notes, which I've also shared with you. So what I would prefer that you do is before class, go over them all, right, the notes, and then while you're here, try to see if you can think up the answers on your own. Because if you know already the information, all you're doing is picking it on the paper, right? So let's see how much you have, you've learned, so to speak. So we have laboratory tests, right? When we think about cardiac, the anatomy and all of that, that's wonderful. So another thing to know is I can't say everything, right? Because it's a whole 6/4 of information or 5/4 of information. So I'm just bringing out the most essentials, right? So obviously you need to know your anatomy, you need to know how the heart works and all of that, right? But when we talk about, heart issues and problems, how do we figure out that there's a problem, right? We're going to do lab tests, right? We're going to look at blood electrolytes, sedimentary rates. What does a sedimentary rate tell us? Do you remember? Inflammation, right? So if there's damage, there's going to be immune response and there's going to be inflammation, and it's going to tell us something. Good job. Then we have the blood coagulation, we have serum cholesterol, blood cultures, enzymes. So these are some of the labs, right? Now, central venous pressure, what is that telling us? What is central venous pressure going to tell us about the heart?
It's basically blood pressure.
Right, it's blood pressure. The heart doesn't work well because the pressure is bad, because there's too much work, right? The pressure on the vessels are so great that it's damaging the cells of the wall. So if we know what the pressure, the central venous pressure is of the body, it tells us, oh, there's going to be pressure on blood vessels anywhere they are. Doesn't matter. So it's good to know that, right? So trends are more important than values, right? Trends are more important. Okay. What about the EKG? What does that tell us? Rhythms. Mm-hmm.
Whether there's adequate perfusion.
Yeah. So if we have an arrhythmia of some type, that's going to tell us, the EKG will tell us that. So what are some arrhythmias? What are some things that the EKG will tell us that the problem would be?
Atrial flutter.
Okay, atrial flutter.
Atrial
Fibrillation.
fibrillation.
VFib. Right, and all of these have a certain, rhythm, a certain rate, and those rates will tell us, okay, there's a problem, okay? If there's a problem, heart's beating too fast, heart is beating too slow, heart is skipping beats, heart is not pumping at all because it's vibrating, that's going to tell us something, okay? What about the angiography? What does that tell us? What the vessels look like. Let's go back to EKG. What are the waves we're looking at? What are they called? P, Q, R, S, T, right? And we know that they should be a certain number and things like that. Good job. So the arteriography and angiography, what do they tell us?
Looking at blood vessels and can you tell if they're occluded?
Right. So the EKG tells us the impulses, but the arteriography and the angiography gives us a look at how it's pumping it. Right? If one is less or not enough, we can see the flow of blood, right? So by definition, we can, the vessels around the heart, usually done with cardiac catheterization. So the medium so injection or of contrast medium into the vascular system to outline an area of the body. How about catheterization? Why would we do catheterization? And what would catheterization tell us?
Clogged cardiac arteries are,
Mm-hmm.
put in a stent.
That's right. So the catheterization will tell us there's a clot, there's a occlusion, we're going to have a problem later, even if we don't have a problem now. And so we're looking at how much occlusion before we begin to worry. 70%, right? If it's 70%, that's when they're going to put the stent in. But if it's not, they're going to do the procedure and they're going to tell the person what? Make lifestyle changes. Like what?
Diet,
exercise. Yeah, definitely. right? So what else? Let's see. So usually where are these catheterizations done? Where parts of the body? Femoral artery, brachial, groin, right? Which is the femoral, yeah. So the wrists are the neck. So the groin, the wrist, the neck. So what's the major thing that we need to do when a person has catheterization done? The biggest thing that we're worried about, because it's an artery, bleeding. So we're going to apply pressure, right? And they're going to tell them not to cross their legs, not to bend their arms, or whatever it is that they have to do to stop the bleeding. But this other part is the clotting, right? If there's a blood clot that forms, that's where the pain happens, and we got to go back, right? All right. So that is the diagnostics, okay? Now let's dive into one of the major problems, right? So if we have angina, what are we worried about? Cardiac death. But before the death happens, which one is the cardiac death? Not exactly the angina. We're worried about that, but the MIs is the cardiac death. The angina is the one that leads to it if we don't resolve the problem, right? So the angina is more like what? The occlusiveness, right? Okay, it's less oxygen is coming to this area. We need to be careful, okay? So by definition, it's coronary blood flow, okay? So let's see. What are some interventions? Well, how do we know? How do we know the person has it? Because you said cardiac death, MI versus angina. How do I know the difference? Pain. I like that. Do they both have pain?
They both have pain.
Yes.
Like, what's the onset of pain?
What is the onset, right? Did I have pain with activity? If I had pain with activity, that's angina. If I had pain just because, that's MI. Because nothing brought it on. It just happened on itself, right? Because it's an accumulation of who knows how many years, whatever I was doing. Okay? So, yep, pain will tell us. And pain where? Chest pain. Sternum, yep. What else? Could be jaw pain. Is women and men different? Yes. Men feel mostly what? Yes. Elephant on my chest. Women feel mostly what? Indigestion, abdominal stuff, right? Which is important to know, because when a woman comes in and she's suffering from indigestion, but it could be a heart problem, we want to rule that out, right? Okay, so the duration is 30 minutes, right? When you say, okay, oh my gosh, I've been having this pain for 30 minutes, then we know, and they're still okay, then we're like, okay, that's possibly an angina. It's hurting and you're still here, it's angina. But if it was an MI, they wouldn't be talking to you, right? So the timing matters. Okay, so it's an angina. What do we do? Nitroglycerin. How? Yep, 3 times every 5 minutes, right? Okay, let's talk about the nitroglycerin. What are some facts we know about that nitroglycerin? It's a vasodilator. With that said, what don't we want to take it with? Yes, good job. Okay, so it's a vasodilator, right? It goes where? Under the tongue. We feel what? How do we know it's working? It feels the tingling, okay? So every 5 minutes up to the 15 minutes, if it doesn't work, then we get help. But we know it's angina because of that. Another thing, the bottle should be dark. It should be stored in a dark place, right? To keep it functional. Okay, so let's see. What do we need to avoid with people who have angina? Smoking, for sure. Mm-hmm. Yes, cholesterol stuff to heighten it and cause more clotting. Extraneous activities, right? That's one too. Let's see. Cold weather, extreme cold weather. So all the things we talked about are going to be part of the teaching about the 5 minutes up to 15 minutes, 1 tablet after each 5-minute interval. The storage, side effects. What are side effects? Hypotension and the headache. Yes. Okay, let's see. All right, let's move on. Let's look at myocardial infarction now. That is a heart attack, okay? And we already said it's different from angina. Why? By definition. It doesn't resolve. Why? Because the tissue is dead. It's dead and dying. See, to me, like the angina, the tissue is going to die if we don't take care of it. The angina, the MI it's closer to death than the other one, right? And so I guess the key thing I'm looking for is the perfusion, right? There is no perfusion in MI. Like, it's blocked. And that's why we have minutes to save that muscle. Angina, there's still perfusion. It's just not getting there fast enough, well enough, or not enough of it, okay? All right, so what else can we say? Wrong one. Okay, so with this one, we have, so by definition, there we go, the causes. What causes is it? Blockage, yeah, high cholesterol, sedentary lifestyle, no activity, poor eating habits, smoking, heart defects, yeah, right? And what are the manifestations? We already said pain. Jaw pain. Yes, right? We could also have cooling, clammy skin, right? We can have that. The blood pressure can be also affected. What else? So labs, what are the labs we're looking at? Troponin. What else? CKMB. Yeah. So we want to make, what do those labs tell us? Whether it's elevated, there's damage that it happened, right? What else? Interventions. What will we do? What will we do for early interventions? Catheterization right away, right? We want to get the passageway open. We want to do a stint, like quick, fast, right? They say, what is it? Time is muscle, right? If we got to rescue them as quickly as we know. What's something that we can give them that could pop that blood vessel and get it diffused? Clot busters, right? Those enzymes. Now, what's the key thing to know about that, though? Not just time. To be sure it is actually a heart attack. Because why?
High risk for bleeding.
High risk for bleeding. Not just high risk. You can't do anything else. Like, you can't put an IV. You can't go do any diagnostics. You can't do anything because anything you do is such a high risk for bleeding, they'll bleed out. So, but if we know that it's a heart attack, we give them that, they resolve, and they're fine, right? So we want to make sure that that's what they have, okay? Let's see, teaching and modifiable factors. So what are we teaching them about their risk factors? What are the risk factors? Okay, yes, it's hereditary. It could be, yeah. Obesity, smoking, lifestyle, eating habits. Yes, stress. That's a good one too, definitely. So so most of those, like we're all prone, Professor, we're all prone. Okay, so those are mostly the, except the hereditary one, they were modifiable. What are some non-modifiable? Age. Yes. Gender. Yeah. Okay. So recognizing non-modifiable. Well, okay. Psychological support. What's the psychological support? What does that do? What is that? What is that? What does that have to do with anything?
Lower stress.
Lower stress, but mostly once a person had a heart attack, first of all, they're so scared. Like, will it happen again? You know, pending sense of doom, right? And so we want to kind of coach them to tell them what are the risk factors and how they can prevent it so they can have a better quality of life afterwards, right? And long-term drug therapy, what would be some long-term drug therapy? Antiplatelets, heparin, aspirin, what else? Blood pressure, medications, right? Anxiety, that could be. Okay, let's move on to the next one. Congestive heart failure, what is that? So by definition, the inability of the heart to meet tissue requirements for oxygen. So no pumping, not pumping effectively, right? So we have right side and we have left side. So what's the difference between right side and left side? I only put the left side here, but there's also, oh, it's over there. If I have a left-sided heart failure, what does that mean? Well, both of them are that, but what's it? Lung. So left affects lung. So we think, how do we know that? It backs up to where it came from, right? So the left side is backing up to where it came from, which is the lung. And so it's going to flood it with fluids, not good. And the right side, it's coming from the body, superior, inferior vena cava, so it backs up. Okay, so what are some of the manifestations of the left side since we mentioned lung issues? Crackles, huge one. Shortness of breath, moist cough, like a wet cough. And then apnea, orthopnea. I can't say it, but so there's issues with when they breathe and when they change position, not breathing, when they change positions, how the blood pressure affects. So if they change position, all the blood rushes to their feet, out of their head, so they want to faint. Whether it's sitting to standing, or lying to sitting, right? Okay. So we have the pulmonary edema that happens. That's why we have these things. Frothy sputum is another one. When they say person is foaming at the mouth, that's possibly because they have left-sided heart failure. The anxiety, we mentioned that, okay? All right, what are we gonna do as nursing interventions? So what? Diuretics, yes, right? Because they have so much fluid in the lungs, and it's like they're suffocating on land, or they're drowning on land, whichever you want to say. So if we give them diuretics, it would remove some of that, alleviate some of that fluid from the lungs, okay? Or the pressure on the heart to pump the fluids, okay? So definitely administer diuretics. What is the fastest diuretic? Lasix, right? That one gives you the most, which tells me what? What is my fear? I mean, it's good because we get rid of the fluid fast. But what's the problem? Say it again?
You can become hypovolemic.
Yes, right? So the same idea about fainting, right? Because the blood is rushing, right? We only want to remove at all times, anytime it has to do with fluid, 1,200 cc's at a time. So whether we're aspirating, whether there's peeing, whatever it is, we don't want to take out too much because the body will feel the effect of it. Okay, so we also, since it's a lung problem, right? We get the diuretics to reduce the lungs. What's another thing we can help with the lung? Oxygen, right? Because they're not breathing well, so give them some oxygen, some O2, right? Fluid restriction, I love it, right? It's too much fluid, so let's restrict their fluid, definitely. And we can do that with the right-sided too, right? So we're gonna, now another thing, let's see. Is this the same one that I'm looking at here? Okay, so let's get to right ventricular. Oh, another one was bed rest, intubation, administered digoxin. What's digoxin do? Increase contractility. So it increases the efficiency of the myocardium as a pump. So if it can pump better, it can help the blood flow out until it gets to the kidney where it's going to excrete it as urine. But if it doesn't pump well, then that's why it's backing up, right? Okay, right ventricular failure. How is that different?
You'll see jugular vein distension.
Yes. Yep, peripheral edema, swelling. Bounding pulses, okay? So let's see, neck, weight gain. When we assess a patient and it's too much weight gain, where do we see it mostly? And they're like, oh, it's a heart thing. Where would we see it? Like we'll put them on a scale and they'll weigh more. That's true. But where would we be able to see it? Or what would they tell us? Swelling feet. Yes, I can't fit my shoes, they'll say. What else would they say? Can't fit my ring, right? Or my face is poofy. So those are things that they'll mention that will tell us, oh, something's wrong. Now, about the weight gain. Like, people gain weight all the time. How do I know it's a fluid thing compared to an rapid? So what's the numbers?
2 pounds or 2 kilograms.
1 pound.
So it's up to 5 pounds a week. So 1 pound, like 1 pound a day in 1 day, something like that. So up to 5 pounds a week, it's a problem because no one gains that much, right?
You underestimate.
Just always
Never mind. Like, speak for yourself, Professor. Okay, so another one is liver enlargement, right? That's another one. So the weight gain, the neck distension, liver enlargement. Let's see, the elevated venous pressure and tachycardia. Why the tachycardia?
It's trying to deal with that.
Yeah, it's working harder in order to get the job done, but that's not going to help it any. It's just going to tire itself out more. What are some interventions? Diuretics again. Oxygen again too. Decrease the fluids. Psychological support, digoxin still, everything's same. Since we're on the topic of digoxin, do you remember some of the issues we might have? Toxicity. How do we know? Nausea. Green halo. I every time that's that icon, I'm like, I have never imagine that, right? I'm like, really? Wow. But there's definitely one. Potassium. Yes. So monitor potassium levels, right? So when we say anything has a toxicity level, what does that bring us to think about? Therapeutic level, which means it has a number, which means you need to know what that is, right? Because most medication you give, you don't care how much you give of it. I mean, obviously you care, but it's like, take, drink some more. No, but what are some other medications, since we're on the topic, that has a threshold or a therapeutic level? Digoxin? Lithium. What are some other medications that have therapeutic levels? Opioids? Which one? Which one has therapy? Like, you have to actually measure it to see that it hasn't reached that level, or else it's called toxic, not opioid. Yeah. So digoxin, you said which one? Lithium? Yes. So, yes. Those are the three that I'm thinking of. Yes. So those are the ones, Haldol, yep. So those are psych meds. So the notion there is, if they have a level that can be toxic, you need to know those numbers. Luckily for us now, they'll give you those numbers, but just know which range they need to be on, okay? They gotta be in the middle. If it's too high or too low, that kind of thing. So about the weight, how do we weigh them? Every day, same time, same clothes, same scale, right? You want to do your best to do that anyway. Okay, so report gain greater than 2 pounds in 1 day. So it's 2 pounds in 1 day, 3 pounds in 1 week. I said 5, but it's 3 pounds in 1 week. I apologize. So 2 pounds in 1 day, 3 pounds in 1 week. That's even worse. Wow. All right, moving on. Let's go to our next slide. So now we're talking about disorders of peripheral vascular disease. So disorders of peripheral vascular. What causes peripheral vascular problems? Heart issues? What causes heart issues? Diabetes. I like that. What's another one? I wasn't thinking about that. That's why. What's another one? Heart issues. Yes. Hyperlipidemia, that's one. Atherosclerosis is what I was thinking about, right? So those cause when you have fat building up in the arteries, and then they cause the decreased oxygenation, right? What are some things that come to mind? So atherosclerosis, fat, substances, what else? What are some disease processes? Let's talk about arterial issues. Which one comes to mind? Say it again. Hypertension is one, yes, but specifically pertaining to, well, that is hypertension. I was thinking about intermittent claudication, right? And this one is an arterial issue, okay? So what is that about? If someone says they have it, what do you expect to see? Okay, when they move, what happens? Pain, yes. So how does the pain go away? Resting. Okay, so that's a key thing, intermittent claudication. And so increase the more you use the extremity, like angina, but in the legs. So there's a tingling, numbness of toes, cool extremities. All right, so what else? What are some other things? I don't have them down here, but some others that come to mind other than intermittent claudication.
Decreased pulse.
Yes, decreased pulses, for sure. Slow, yes, ulcers.
No hair.
No hair, different color, shiny skin. Yes. Let's see. Raynaud's disease. Which one is that one? Yes. So what happens? Cold, vasoconstriction happens, and so it turns white. Then when vasodilation happens, then it turns red. But from white to blue to red, and it's painful, right? Then we have, there's the other one. Berger's disease. You remember that one? That's also, that one has to do with smoking. So the way to stop it is to stop smoking, but it also is a arterial kind of thing. So Berger's disease. Okay, so Berger-Allen exercise, they say, to help you with that. But anyway, so how do we rectify those problems, arterial problems? Give me some pointers.
Well,
Let's start with arteries. Okay, no, not smoking. Don't cross your legs. I like it. What about dangling? What about this thing? Right? So which one is for which?
We like dangling
For which one?
arterial.
For arterial. So wait, let's think about this. I always lose it. So yes. So A, because this one looks like an A, and B, because this one looks like a B. You're right. There you go. But I like to understand why. So the valves are working how? What do the valves do again? They bring blood up, right? So that's why the V is this way, right? And then A, bring blood to, okay? All right. A, away from the heart, but it's bringing to the extremity. That's why you want to dangle it, because it's not doing its job. Okay. What else could we say? That's what I can think of. Okay. Here goes the Berger's disease. Thromboangiitis obliterans. Okay, so the Berger's disease definition refers to inflammation of the arteries and veins of lower and upper extremities, resulting in thrombus and occlusion. Right, so characteristics: it occurs in 20 to 40-year-old people. It's most common pain in the legs, tingling of the toes. So how to fix it? Stop smoking. Raynaud's vasospasmic or obstructive conditions of arteries. Arterial vasoconstriction results in cold, pallor, and pain. And there's a color change, the blue to red. So pale to blue, then to red. Nursing interventions, what are we doing for them? We're telling them to stop smoking. Since the Raynaud's one has to do with cold, you don't want to tell them to move out of the cold, or to wear gloves so that they can warm their extremity. Also, you can administer nifedipine. That's the drug of choice. Let's see. Monitor their blood pressure, because obviously the blood is being circulating poorly. That's why the red to non-circulation, that kind of thing. Let's see. So let's talk a little bit about hypertension. Tell me what you know about hypertension. What is primary hypertension? You don't know the cause. So that means what is secondary then? Underlying, like what? What could cause it? Diabetes could cause it. Pregnancy can cause it. Medications? Yep, hypothyroidism can cause it. What is this pheochromocytoma? It's a cancer. It's a tumor in your brain that can cause hypertension. Okay? So that's another reason why we can have hypertension. And then we have renal issues. How is the kidney affected by hypertension? Lack of perfusion. So what does it do? It's destroyed, because there's no blood, there's no life. So if it's destroyed, what's not happening? You're not filtering. If you're not filtering, what are you not doing? You're not urinating, right? And so the next step would be not death, dialysis, then death. I'm kidding. Yeah, so let's talk a little bit about dialysis, okay? What kinds are there? Hemo and peritoneal. What's the difference? Yes, it could be different places but it's an artery. So you can have like the valve one, you can have the anastomosis one. It could be in your arm, it could be in your thigh, femoral. So that just means it's going through your blood. And then we said the peritoneal one is going into your stomach. Okay, the idea is the same. You have a dialysate that has salty whatevers, and water follows salt. So they bring the blood into it, and because that thing is saltier than your blood. So it pulls the fluid from your blood and then it filters it. So what is the one major thing that we have to do when a person is going to dialysis? Yes, fluid, right? We want to weigh them so we can see how much fluid is being taken out. Because we said we always have to take a certain amount or else what happens? Hypovolemic. And so how do they look when they're hypovolemic? Tachycardia, cramp, pain, yeah, pallor, all of that. Awesome. Okay, and then the peritoneal. So what's the worst thing that can happen with hemodialysis? Yes, the site. The site could be occluded, right? Or the site can get infected, right? So that's really the worst thing. God forbid if it was one of the anastomosis ones and it wasn't ready, what could happen? It can burst, right? So do you remember that one? So it's like they say the example is when it's fresh, it's like a balloon. So when you poke a balloon, it bursts. But when it's mature, it's like a football. If you poke a football, it doesn't burst. So we want it to take time. So like usually when a person starts with dialysis, they won't start with the anastomosis. They start with like the catheter one, right? And then they do that. But you can't keep that because that's a foreign body. So it's a certain amount of time. But because is every dialysis for life? No. We can have acute renal failure and we have chronic renal failure. So a person with acute, so we'll get into it, but really quickly, what would cause you to have acute renal failure? A UTI, yeah, right? Or you're not drinking, right? So that could cause it. So if you resolve that, you're better. It takes a day or two, but you're fine. But obviously, if it's diabetes or hypertension, that's chronic. Then you need the anastomosis one, right? So, okay, so now we talk about the dialysis. How about the, what do we do? Do I touch it? Okay. Wait.
Keep it on.
Oh, I have to keep it on.
Not in this issue.
Okay. Making me work. Okay. All right. So the dialysis now, for the peritoneal, what are some things that we have to think about that one? Peritonitis, right? Because it's something outside going in. Same thing when we have infections with the hemodialysis, we have infections there too. So we have to constantly monitor the tube that's in there. Same idea with the dialysate. You have some fluid and it have like hang time, dwell time, and then drain time, right? So it takes longer, but the person can do it in the comfort of their own home. That's a good thing. What else? Yes.
Why do you hold BP meds?
That's a great question. Thank you. I would have forgotten to say that. So you hold it because it's going to clean it out, right? It's going to wash all the medication. However, you don't send them if the blood pressure is high. So you would give them the blood pressure medication at a certain time so that it can, within an hour, it will work, right? And then an hour or two, I think usually, like if the blood pressure medication is like 6, they'll go to dialysis like at 12. At least it worked, and then their blood pressure is good. The medication has already done its job, so it's not really washing out anything. But if it's like right before, you don't want to do that, right? But something like aspirin, you can give aspirin, because what is something that's in the dialysate that something that is in the diastylate that's kind of like aspirin? It starts with H. Heparin, yes, heparin. Why is that? Yes, right, because it's a machine, right? And it's doing its thing, and you don't want it to clot. And when it gets into your body, all that movement, all that changing, you don't want it to clot. What's another thing that they give them as well? Because, okay, I'm going to give you the reason why, and then you tell me what that thing is. The reason why is because as they're doing the filtering, some blood cells are dying. And so the body sometimes might get less blood back than it originally took out, right? But we need our blood for life. So what would they give them to help them? Yes, erythropoietin, but it's called epigen. But the erythropoietin is what our body makes, right? Yeah. And so we make that because we know the blood is going through a process and some of them might die because of the activity or whatever. So we want the body to create more blood so it can have as much as it needs, right? Because some people who have dialysis, sometimes they can have, weakness and all of that. So, okay, good job, guys. Let's see, what else? Anything else here? Maintaining salt restriction. So this is like, okay, how do we prevent hypertension from happening? One of them is the diet, right? Reduce salts. What else? What is another thing we can do to help hypertension? Exercise. Basically. Less stress, exercise, eat right, right? Let's see, anything here? Okay, so let's say now we need to give them medication. What are we giving them? Diuretics. Yes. What else? What other medications? Tylenol, propanol, right? Depending on what we need it to do for them, right? Everyone has their own type, but those are blood pressure medications, right? Metoprolol. What else? Interventions. What are we going to do when we have a diabetic patient? What are we going to do for them? What's our job? When they have hypertension. Our job as nurses when we get the patient with hypertension is what? Control their blood pressure by giving them their medication. That's our job. We also make sure that they eat well, that they exercise, all of that. But the main thing is definitely the medication, right? We also give hydralazine, calcium agonist. So this is the pharm part, which we'll get into a little later. But captopril, lisinopril. So we have ACE inhibitors. What's the difference between? No. What's the one thing you should remember about ACE inhibitors? Yeah, that irritating cough. Now, so we mentioned all these other medications. So there's a variety. So if a patient is not compliant, what should we tell them? There's another med for that, right? It's like there's an app for that. We can give you something else. Just let us know that, you're not taking for whatever reason, okay? Is it diltiazem? There's some, diltiazem. Who don't we give diltiazem to? Because it causes flushing. People who take, I think it's Viagra. People who are taking Viagra, we don't give them diltiazem. It's something like that. Because it causes a flushing. Angioedema, yes. And so, yeah. Okay, major side effect. Okay. All right, let's move on. Let's talk about, what time is it? Okay. 15 more minutes. Thrombophlebitis. Okay, so by definition, it's a clot in the vein with inflammation of the wall. Okay, so we have precipitating factors. What are some precipitating factors? What would cause thrombophlebitis? Yeah, so what causes clots? Sedentary, yes. So that's why we're so afraid with which heart problem? The flutter, right? Yeah, atrial fibrillation, VTAC. We're afraid because it's not moving. So because it's not moving, it can clot easily. So we always give them aspirins, right? So stasis, hypercoagulation. That's just a genetic thing. Some people just clot faster than others. Whereas some people bleed faster. What are they called? Hemophilias, yes. Damage to an intima of the blood vessel. So some trauma can cause clotting. Pregnancy or estrogen can cause clotting. Malignancy or obesity can cause more clotting. Now that, okay, when we have a lot of clotting, what are some of the things that we're going to see? Like, how do you identify someone who has blood clots? What is one type of blood clot? Let's say that you get, let's say if you traveled or you were pregnant and you were laying on the table. Yes. So what are some signs that person has that?
Unilateral swelling.
Yes. Right, so one side, so there's the swelling, there's the pain, there's the warmth, right? So that's how you will notice. So edema, localized swelling, bump, or knotty, red, tender, local induration, right? So those are examples. So you see how I did that? Like, sometimes I ask you a question and you're like, drew a blank. But because you knew about that one kind, it brings the information, right? So that's what you do. Associate it with one thing and then remember about that. And then it'll bring all the other facts to you, okay? So speaking of that, what's Holmes' sign? Dorsiflex the foot, and if there's pain in the back of the calf, there is a clot there. Yeah, and it usually happens mostly in who again? Pregnant women, and it happens because again, they're not moving easily. They're not moving at all. They were there for a long time. Okay, so how do we help a person to dissolve their clots or not form clots, or what do we do? What's the nursing intervention when a person has clots? Elevate the legs, yeah. What compression stockings? What don't we do? You can rest if they have it, but if they don't, if they have it, what don't you do to that area? Massage it, right? Because it could travel. And pulmonary embolism. Yep. Okay. So it's painful. So what do? Pain meds, right? We give them pain meds. Because it's a clot, it's a clump of blood. It possibly clotted because it was not flowing properly. So what else could we do? Fluids, yes. Encourage deep breathing. Why are we encouraging deep breathing? What does deep breathing have to do with a clot? So when we don't have a clot, causes no oxygen to whatever extremity. So you want to keep breathing well so that you can have as much oxygen in your system so that when the clot is dissolved, whatever, it can get the oxygen to diffuse, right? So you want to make sure they're encouraging deep breathing, especially if it's in the lungs, right? Depending on where it is. What kind of clots can there be? What can cause the clot? What can cause the clot? No, vitamin K will help not clot. Right? No, will cause clot. Never mind. I hear you. Never mind. That's not what I was looking for, though.
So if it originates in the heart, doesn't it tend to go to the lungs?
So what can cause it? Blood clots, fat, embolism, or air. That's what I was looking for. But yes, vitamin K is anti, right? Green leafy vegetables will help you, and vitamin K. Speaking of vitamin K, who do we give vitamin K to? That you for babies, right? Because they don't have it. So where that whole concept of giving babies vitamin K, what did that teach you? Why did we do that? Why did we have to give them? Why don't they have it?
Because they don't have the ability to do it.
Because where is it? Not the liver. Their gut. It's the bacteria in the gut that produces vitamin K. Since they didn't eat yet, they didn't have bacteria yet, so they don't have vitamin K yet. But you are right, the liver is not well produced as well. So that's why they have. So the vitamin K caused them to be able to bleed, but the liver caused them to have what? Because of the bleeding. What do we see? Jaundice, right? So the jaundice is caused because the liver is immature, because once the bleeding happens and it's being broken down, they have nothing to help process it. The liver is not mature enough, okay? And we'll get into that. You know, there are two kinds, all of that, okay? I know. For babies, poor liver, poor lungs. Okay, let's get into shock. Do we have time? We have time for a little bit. Oh, this is our last one. Yay, I made good timing. Okay, let's talk about shock, right? So by definition, it is the lack of oxygen and nutrients at the cellular level due to impaired tissue perfusion for cellular metabolism, regardless of etiology. Okay, so what concept is this reminding you of that we were just talking about with fluids? Hypovolemic, that's right. So if we don't have enough, right, that's going to be a problem. And we're going to see the different types. We have cardiogenic, hypovolemic, and distributive, okay? So cardiogenic is the failure of the heart to pump adequately, okay? Hypovolemic, we've mentioned already, decreased blood volume. And distribution, there's 3 kinds. Do you remember? Yes, neurogenic, anaphylactic, septic. Good job. Or are you just looking? It's okay, whether you're looking or not. Great job. So with the neurogenic, increased size of vascular bed due to loss of vascular tone, and anaphylaxis, hypersensitivity reaction, and septic, systemic reaction, vasodilation due to infection flushed. Okay, so since I think about anaphylactic, and it says hypersensitivity, what is that referring to? Allergies, right? Whatever substance that you have ingested, the body doesn't like it, and swelling happens, right? When we think about like it's red blood cells, white blood cells, platelets, they're coming to attack whatever they think is causing a problem, and they don't really find it because it's not a disease, and they just proliferate and then swell things up and close things up, right? Okay, let's talk about the general manifestations. So what will you find when a person has shock? Increased heart rate. So tachycardia. Since you have increased heart rate, you'll always have increased respiration. So tachypnea. What's another one? Hypotension or hyper? Hypotension, yes. What else? Diaphoretic, yes. So since we talk about diaphoretic, what's the feeling there? Cool and clammy. So the cool, moist skin. And diaphoretic, cool, makes us think of cold, which makes us think of less blood, so there's pallor, right? And hypotension, all of that. And then we have metabolic acidosis, which we'll get into when we get to respirations. Metabolic acidosis. Remember what that does? What is that again? Metabolism is causing the body to be acidic, right? We'll get into that. We'll be reminded of that, okay? And then decreased level of consciousness. That also plays a part with the metabolic acidosis, right? When things are being fried in your brain and your proteins and everything is not working well, okay? Interventions. What do we do with a person with shock? Depending on what it is, right? If it's hypovolemic, we increase their fluid. Somebody said something else. We elevate their legs to help blood flow better. What else? Give them epinephrine. We give them IVs, right? What are some drugs we give them? Epinephrine, we said that. Atropine, norepinephrine, yes. Dopamine, dobutamine. Yeah, and that's that. So those are the emergency. Emergency, atropine, dopamine, epinephrine, isoproterenol, dobutamine, and norepinephrine. Okay? And that's that. Any questions?
I do.
Not on that? Okay, so we're all done.